Great. Thank you all so much for joining us. I know it'll take a moment for people to come in, but we'll go ahead and get started. Especially thank you for joining us over what is the lunch hour for many of you, or maybe the immediate post-lunch period for those on the East Coast. My name is Emmy Betts. I'm an associate professor of emergency medicine, and I am the deputy director of the Injury Center at the University of Colorado Anschutz, the Program for Injury Prevention, Education, and Research. Today's presentation is part of our monthly Research2Practice webinar series, where we really try to talk about both the latest research in injury prevention as well as how it's applied in practice. And I think one of the things we'll see today is also how our experiences in practice inform then the kinds of research that's going on. So first, please mark your calendars for our next webinar, which will be November 1st. It'll be co-hosted with the Department of Epidemiology at the Colorado School of Public Health, and it will focus on harm reduction and overdose prevention. A few housekeeping tips. So I'm going to start a poll. If people could please take a moment to fill it out. Our speakers are interested in knowing your occupation, your background related to trauma-informed care, and I think that that'll help guide some of the discussion today. Please put any questions into the Q&A box, which you should see at the bottom. We will be having a facilitated Q&A session at the end. And this webinar will be recorded, and the recording link will be available afterwards and will be emailed to you. So while people are answering the poll, I'm going to launch into introductions of our wonderful speakers. I'll introduce both of them now and then turn it over to them. So today's webinar is looking at the basics of forensic nursing, as well as health and legal outcomes related to interpersonal violence cases. Our first speaker will be Lucero-Foote, who is the forensic nurse manager at UCHealth, and I am very fortunate to be able to work with her and her team in the emergency department. She'll be presenting some basics of the program as well as our local data. She has been a licensed registered nurse in Colorado for almost 20 years and has a focus on critical care. Her training was at Creighton University, and then for the past decade, she's worked as a forensic nurse examiner, or FNE. She currently manages the FNE team at our hospital, as I mentioned, where she's developed really a robust orientation program, as well as education and training for ongoing performance competencies. She also created a strangulation pathway for clinical care that I think, unfortunately, it feels like we're using more and more often these days. Her other clinical experiences as a forensic nurse have included death investigation, correctional nursing, sexual assault, intimate partner violence, physical assault, strangulation, elder abuse, child abuse, and human trafficking. Big stuff. She's also board certified as a sexual assault nurse examiner for adults, adolescents, and pediatrics. So after she speaks, then we'll turn over to Dr. Annie Lewis-O'Connor, who is going to talk about trauma-informed framework and how it applies to both practice and research. She is a dually board-certified pediatric and women's health nurse practitioner, and she's the founder and director of the C.A.R.E Clinic, which stands for Coordinated Approach to Resilience and Empowerment, and co-chair of the Mass General Brigham Trauma-Informed Care Initiative. Her clinic is really committed to providing patient-centered trauma-informed healthcare to people who have experienced individual, interpersonal, or collective trauma. Dr. Lewis-O'Connor really addresses violence in 4 pillars, so research, policy, education, and clinical practice, which I love. That's a lot what we are doing here in our program as well. She has numerous publications on a variety of topics related to violence and health. And then her current research is focused on measuring trauma-informed care, models of care in adult health settings, and exploration of the best screening methods. And with that, I will turn it over. I'm going to end the poll, and hopefully, let's see, looks like we've got a mix of some nurses, about 22% nurses, 11% physicians, 11% researchers, 44% students, 22% other. So with that, I'm going to end the poll and turn it over to Christine. Thank you so much for joining us.
Thank you so much. Let me get my screen up here. Can you just confirm you can see my PowerPoint?
Yep, we can see it.
Awesome. So thank you so much for that really kind introduction. So I'm just going to give a brief overview today on what is a forensic nurse examiner, some of the things our program does. If you are not working somewhere that's fortunate to have a comprehensive forensics program, and then a little bit about our specific data at the University of Colorado Hospital. So to start out with, a forensic nurse examiner, or FNE, is a registered nurse who is specially trained to provide comprehensive health care to survivors of violence and assault. And I also just want to point out, we also do suspects. That is something that we pride ourselves on to make sure that we are non-biased. So for example, police will bring us suspects potentially of sexual assaults, and even of our other patient populations. There's many times when our patients are both the victim and the suspect within that one assault. Certainly everybody gets the same care across the board. So we will do something that's called a medical forensic exam. Important to note, medical is first, always comes first, but the nurses are trained in forensic care and evidentiary collection. And then everybody on the team also does additional expert witness testimony training. So when they're called for their patients to testify in court, it does go beyond as a fact witness, and it is an expert, somebody that can render an opinion. The nurses are well trained in the trauma response. This includes, the foundation of the neurobiology of trauma, battered women syndrome, those types of things, trauma-informed care, which my colleague will be speaking about here after me. And then we work with a multidisciplinary team. So we certainly work with law enforcement quite a bit, advocacy with our community partners. There's different advocates that work either within the police stations or at nonprofit locations in the community setting. And then resources. We're very focused on resources within our communities that we can assist patients with, whether that be victim compensation or following up at the ID clinic if they were started on NPEP for HIV, or even things like just connecting with therapy groups, things like that. I do like to address this. I know this comes up a lot, but the difference between SANE and FNE. SANE is a sexual assault nurse examiner. So those are nurses that are only trained in the care of sexual assault patients. We are a comprehensive forensics program at university, so we are FNEs. So there are lots of hospitals in the state of Colorado and across the country that just do SANE. In fact, that's probably more common. It is rare to see a comprehensive FNE program. So I do have a few studies I just want to cite on the next few slides about why FNE. We can train anybody to collect swabs. I don't disagree with that. And before FNEs really took a huge, kind of awareness in the healthcare arena, physicians and, ER nurses were doing, for example, sexual assault kits. So why buy into having someone specially trained? Well, this was a study from 2003. So this was quite a while ago. It was done here in Colorado. Val Severs, the lead author on this, was actually my mentor, not only when I first became a forensic nurse, but also in my graduate studies. And she put this research out in 2003 about the benefits of using a trained nurse, increasing the comfort of the victim, providing private, safe, and secure environments, developing rapport and trust. If you increase the comfort and trust of the patient, that would correlate with a greater likelihood of the patient to report, undergo evidence collection, and be willing to cooperate with prosecution. Obviously, if someone is specially trained in this, they're going to collect a greater quantity and quality of evidence. Certainly saves time in the emergency department when you have someone trained, always important as we're having to report out our throughput times. And then if you see someone quicker and are readily available and can complete the exam quicker, obviously you'll have a better recovery of time-dependent material. FNEs provide a more consistent and broad healthcare services. All the nurses are well versed in sexually transmitted infection treatment, pregnancy testing, prophylaxis, and then those comprehensive referrals like advocacy, victims compensation, infectious disease, things like that. Then our research did show some legal advantages. Again, our focus is healthcare. We perform the medical care first and foremost, but there are going to be legal advantages, right? So 79% willing to report versus 50, 88% that would have evidence collected versus 30, more charges being filed, higher conviction rates, and longer sentences, safety for our families. This was a study that I found that quoted several studies have highlighted the benefits of the presence of forensic nurses in healthcare systems, namely empathy, support, strengthening the sense of control, and empowerment of most patients by improved practice of nurses is achieved through better patient care, increased patient safety and accessibility to services, decreased load of healthcare system, increased patient satisfaction, elevated professional skills, increased credibility as well as accountability, and increased prosecution of criminals. So there's certainly some legal advantages that we recognize, but first and foremost, I want everyone to be aware of the health outcomes that will be improved for this patient. The average exam that we're finding takes 3 to 4 hours. I do have a slide total time gives 100% to these patients, how to follow up with police, how to file this victim's compensation report, making sure they go to therapy, all of those things that the ER is not going to be able to follow up on. We find quite regularly that our patients do have a whole host of questions days and weeks after the event. We have some patients that call our forensic office even months afterwards with questions or just to share with us that, you know, the support we gave them allowed them to go through with this, you know, encouraged them to go seek therapy, all of those things. And so we definitely don't want to mitigate the significant health outcomes that we provide for our patients. This was another item that I retrieved off of the Cleveland Clinic. They have a very robust forensic nursing program as well. This was retrieved from their website. Forensic nurses often spend several hours with patients depending on the amount and types of injury. Their first priority is to ensure patients are treated medically. Then they begin the forensic exam, which includes evaluation for collection of biological evidence, documentation of assault history and current injuries, photo documentation of injuries, assistance with reporting to law enforcement, and referrals for follow-up care. They bring a trauma-informed approach to helping patients, help patients regain control, and photo document injuries. This is super important because I do pride myself on the fact that our team, they are the injury experts for the health system. We often find when we review the physician or the registered nurse that was primary, we review their documentation as we prepare for court. Often we find that injuries are misidentified and the documentation is not thorough. It doesn't include the size, the shape, the location. We measure every single injury. We ask the patient if they recall how they got it. And then we talk about that in court, right? This contusion, for example, is ruptured blood vessels underneath the skin, and that's result from blunt force trauma. So we're able to connect all those medical pieces when we go to court. Also, the trauma-informed approach is huge, again, which my colleague will be speaking about in a little bit, and helping these patients regain control, which is hugely important because all of these patients that are victims of some type of violence or assault had control taken from them during that event. Again, another study, and this is specific to DV since it is DV Awareness Month. I wanted to add this one in here. Interpersonal violence, or IPV, is a pervasive issue across the United States, affecting 1 in 5 women and costing the nation up to $750 billion per year in healthcare spending. Prevention of IPV by forensic nurses may be an under-recognized and underutilized activity, as forensic nursing emphasizes collection of evidence and provision of acute care to victims of violence. The role for forensic nurses to inform, participate, and implement primary, secondary, and tertiary prevention activities can have positive influences on the problem of IPV that extends well beyond the provision of direct care. Forensic nurses bring an increased level of understanding of the dynamics involved with victimization and perpetration, as well as the holistic focus of nursing care to this practice arena. Forensic nurses are very involved in prevention at the community level. I know myself and my colleagues were regularly doing educations and trainings. We speak at high schools, at middle schools, teaching dating violence, healthy relationships. We find in many of our patients, this has never been taught in a home setting or in a formal education setting. And many of our patients have no idea what the attributes of a healthy relationship are. We do extensive education with this on our patients, and many realize in that moment during their exam with us that they are in an unhealthy relationship and never knew that before. So I absolutely, know firsthand that forensic nurses play a huge role in prevention. Again, just something else to help everyone understand that it's not that legal focus. It's not just being a swab collector. It is so much more, and we're bringing that nursing care to the bedside. So the forensics program at University of Colorado, and just to let everyone know too, we also cover the Highlands Ranch campus, our new Highlands Ranch hospital. We see all victims or suspects of abuse and violence, including sexual assault, strangulation, elder abuse, adolescent and youth abuse, human trafficking, domestic violence, or what we now call interpersonal violence, gunshot wounds, stabbings, vehicular assault, so hit and runs or auto versus pedestrian, all of those types of things. For our patients that are alert and oriented and can provide consent, we will offer that full medical forensic exam, which would potentially include things like a pelvic exam, genital specimen collections, any type of biological evidence, really, anything that we feel has evidentiary value. And that could be clothing, that could be swabs on, the body, genital swabs, all sorts of things. For our patients that are unconscious, we can perform general nursing tasks, right, that don't require a separate consent. And that includes a full head to toe assessment, injury documentation, wound photography, if we feel it would enhance the medical record. But again, that SA kit, the sexual assault kit, anything sensitive like genital evidence collection, we wouldn't do that on someone that's unconscious. So that would have to be obtained either through a court order, a medical durable power of attorney, or we would wait until the patient regains consciousness if we feel that might happen. So there are things we can do with unconscious patients without additional consent, and then other things that would have to wait. So what happens first and foremost in our patients, if we're going to do that full medical forensic exam, is we want to get consent, which is a separate consent form. We go through lots of paperwork in these exams. Discussing community advocates, we do get those folks involved right away, whether that be our community folks, like perhaps our sexual assault advocates at Blue Bench, or a police advocate. We start, talking to the patient about victims' compensation, their reporting options. Is this something that's a mandatory report, or is this something that the patient doesn't have to, work with police, in which case we wouldn't notify police? So we have all these different things we talk to the patient about. We do get a detailed history of the events, specifically of the events that pertain to their body. We explain to patients, police are going to get information from you as well. That's going to focus more on their investigation, which isn't medical, right? What color hat was the person wearing, or what kind of car did they drive, or, those types of events. We're not asking those things. We're asking specifically medical questions. What happened to your body? What's hurting? What's bleeding? What position were you in when this happened? We're focused again on the medical aspect. And it's important because that detailed history that we get is allowed to be shared in court. We have the medical exception to hearsay. Whereas if that patient told a friend, or even in some cases, an advocate or a police officer, it would be considered hearsay and can't be shared with the jury. We do that very, very thorough head to toe assessment, which, most of us are doing focused assessments on our patients, but this is that really thorough head to toe that we first learned about in our training that takes quite a while, to be honest. No part of their body is left unlooked at. We look in their mouths, we look in their ears, we check, the cardinal gazes. We do a very thorough cranial nerve assessment. We look over every part of their body, and then we take photos of things that we feel would be valuable to the medical chart for enhancement of documentation. We do a detailed anogenital assessment, of course, on the patients that have any assaults that involved genitalia. We collect any evidence if that's applicable. We do digital photography of injuries. We use a Canon camera as well as a colposcope, and then the discharge instructions. This is just a quick picture of our body surface trauma. We would use a traumagram and how detailed, we click on the spot where the injury and then how detailed each description is. We include a measurement. All of our photos include a standard. We use the ABFO ruler. The color, the type of injury itself, was there pain and tenderness? Was there pruritus? All those types of things. So very, very detailed injury documentation. All of our photos are from 3 different pictures. We do, a further away that gives us orientation on the body, up close, and then again up close with our ABFO ruler for measurement. The forensic nurse has to consider lots of things like lighting. Is there any shadowing? Do we need to utilize perhaps oblique lighting for this? Flash, no flash, shutter speed, aperture, all sorts of things that, we would learn about. And then we also use some other enhanced instruments and equipment. We have a negative invert filter, and then we also use alternative light sources, not only for fluorescence of possible bodily secretions, but also to look for areas of absorption for possible subclinical bruising. So lots of different ways that we are assessing the patient for injuries. Again, listening to that history. What types of blunt force or penetrating trauma history did they give us? And then correlating that to our findings. This is a picture of a colposcope. Many of you may know it for use of genital assessments. We also use it for oral assessments. A colposcope does not go inside a patient's body. It's a binocular microscope. Ours goes up to 15 times magnification. So we can really see some of those small, minute injuries, like perhaps petechiae on the uvula, or maybe a single petechiae, in the ear, or something like that. So we do use the colposcope for things other than just genital assessments. Other responsibilities, obviously discharge teaching, safety planning, and then the expert witness testimony. All of these exams are tailored to the patient. Again, it's about restoring control as well. So the patient is in control of everything that is done. We will explain everything and possible implications of not doing something, or our inability to maybe assess and thoroughly help the patient know if they do have any injury or abnormalities. But ultimately they can still say, nope, I don't want to do that. And then I just wanted to go into some statistics. I know there's been a lot of questions, how has your volume been affected by COVID or things like that. These statistics are updated through August. Unfortunately, September's not updated yet. I do know that we saw a total of 166 patients in September. I don't have any other breakdowns though, so I didn't include that on these. But what I have here is I'm also showing the data from a year ago. So 2019 is in the gold color, and then 2020 is the red. You can definitely see how our volumes jumped up in June, July, and August. I can't definitively say this is from COVID. We know that we also have higher volumes in the summertime, just in the ER in general, and also trauma patients. Trauma volumes go up, which makes up some of our patient populations, right, with gunshot wounds and stabbings. But I still think it's interesting to see, just even if you compare to 2019, how much higher our volumes are. I also, of course, attribute that to our frontline staff who are more aware of our program and who are consulting us more often. We're getting even consults if healthcare providers have questions about their mandatory reporting obligations, which I think is great. I 100% understand that mandatory reporting is sometimes confusing, complex, it can change, right? In the state of Colorado, for example, it changed a few years ago, and that we're no longer mandatory reporters for domestic violence. And so just certain things that get confusing or maybe have changed since you've been in practice. So we love getting consulted to assist healthcare providers with things like that as well. This is by gender. And I think it's important that we do not forget about our male patients. We do know that for sexual assaults, it's about 1 in 4 women in their lifetime, but men is not too far behind at 1 in 6. And so we have to be just as diligent in screening our male patients for sexual violence, for domestic violence, and all of those types of things. time spent with our patients. So this is where I just want to show that this is just wouldn't be feasible for, let's say a primary ER nurse who has a patient load of 4 and 5 patients. So maximum times you can see have gone all the way up in June to 10 hours. That could be very, very complex exams or patients that needed lots of breaks to stop and recollect their thoughts, or even, maybe there were delays in seeing the patient because we had multiple patients presenting at once. So maybe we started some things like urine and blood specimen collections and then had to come back. But the average there is in yellow. So you can see majority of the time our exams are taking between 3 and 4 hours. Again, these are very, very thorough. And so that's another reason why they take so long. But also we're allowing the patient time to have some of those emotions. And we work through some of that with the patient initially, right? Because our patients are going to have a lot of emotions as they start to realize certain things. Maybe we do some healthy relationship teaching with them and they realize that they have been in an unhealthy relationship. And all those emotions come to the forefront. We help the patient working through all that. This is just a glance of all the types of crimes reported broken down. So we have assault, elder abuse, human trafficking, intimate partner violence, sexual assault, strangulation. DFSA is drugs used to facilitate a sexual assault. So if we have a possible drugging, gunshots, auto-ped stabbings, and then we do have an unknown if it wasn't really clear. And some of our patients have co-occurrence, right? So maybe they were here for a sexual assault, but it also was within a domestic relationship. So it was also DV. So sometimes, there's multiple types of violence or assault happening within the one patient situation that we're encountering. Again, you can see here of note, sexual assaults did go up a little bit in June. And in August again, in the mid-20s there from the teens that we were seeing before that. Also, you can see here gunshot wounds obviously went up. So yes, higher acuity, more violence, absolutely we're seeing. Again, I can't say it's directly linked to COVID. Could be that it's summer months, right? More people are out and about, more house parties or whatnot. Who knows? It's hard to say that specifically this high increase in gunshot wounds is specifically to COVID, but we do know we have seen a lot more violent trauma over the summer months. Anecdotally, the things we're seeing just a lot more intense, more vicious stabbings, more gunshot wounds, even the types of physical assaults that we're seeing, more SBI or serious bodily injury we're noting within our exams. So, I do think we've all felt that perhaps with the patient populations we're seeing if we're working in the emergency departments and things like that. But the other thing I just want to point out is this is strictly with the exams we're doing. We see a lot of patients that we do just what's called a consult on, where we do help them maybe with safety planning or connecting them with community resources, but they just don't want to talk about the exam. They don't want us to do any injury documentation. They don't want us to look over their bodies. And so consults are not reflected in this. Those are separate. We do quite a few consults every month as well. We also spend, anywhere from 30 minutes to 2 hours with our consults, depending on how much or how little they want to do. So I know, for example, like human trafficking on here, it's like, oh, well, you've only had one exam this year. That's correct. But we've had lots of consults, and that's a population we specifically see that they are really scared to do too much with us because of their unsafe situation. They don't want police involved. They don't want to give us a history and tell us about the details and things like that. So just another thing to keep in mind when you're looking at this data, this is strictly for exams that were completed and doesn't include the patients that we're connected to that don't have a full exam. I see on here DFSA, a question about that. That is the drugs used to facilitate a sexual assault. And so I'm just trying to, I think that was it for in the Q&A box. Let me just check the chat here. Yeah, so there was a question about correlation to COVID and stay-at-home orders. I mean, absolutely, that's a theory. We can't say definitively, but we do think that perhaps there was more domestic violence as people were cooped up with their perpetrators. Let's see. And then There's another comment here, IPV went down, but the acuity of cases with IPV was significantly up. So yeah, I mean, there's a lot of theories, a lot of things we can attribute to, you know, we do extensive safety planning with all of our patients. I think that's another piece that's missing, especially in a, you know, a high turnover area like an emergency department. You know, great that social work can certainly help the patient find a shelter for maybe a night or two, but then what? And that's where we come into play. You know, we're helping these patients develop long-term safety planning. What's going to happen in a night or two when you have to go back to the real world, right? You can't hide out in this shelter forever. Are you safe to go back to work? How are you going to bring in income? Are there children involved? Are there pets involved? What's the long-term plan going to look like? Do you have family? Can you get out of this state? Or, you know, those types of things. And often, you know, I think a lot of healthcare providers are unfortunately under the thought process that, oh, if we report to police and they get away from the situation, they're safe. And there was a study that was put out by IVAWI and Violence Against Women International a while back that said of DV homicides, 70% actually occurred when the patient, quote unquote, left the relationship. So that tells us that leaving the relationship is not necessarily safe, right? And even things like helping the patient get a restraining order, most criminals aren't going to follow a piece of paper, right? A restraining order is great. It starts the documentation process, but it's not going to guarantee this patient's safety. And so those are a lot of things where the forensic nurse is going to come into play. We have the time and the knowledge of our community resources to do that extensive safety planning with this patient beyond just what, you know, where you're going to go tonight. And maybe if it's not even safe to leave the relationship right now, right? So we'll do some education with the patient about what they can do maybe over time or behind the scenes, but stay in that relationship because that might be the safest thing for that patient at this moment. So that's the end of my sharing. I'm going to stop here so my colleague, Dr. Lewis O'Connor, can share her screen. I don't see any new questions popping up in the Q&A, but I'm happy to circle back if more come up later.
Great. Yeah, thank you so much to the and to the audience. Please do keep putting questions either in the Q&A or the chat, and we can have more discussion at the end. We'll turn it over to Dr. Lewis O'Connor.
Hello, everyone. How's everyone doing today? I've lost, what have I lost? Are my slides up?
Your slides are up. We can't see you, but we can see your slide.
And I can't see you. All I can see is my slides. That's interesting. It's like the whole Zoom's gone, but you're all there?
Yeah, and now I just see a big save to this PC picture.
Let me just stop share for a second.
Try it again.
That's what they say. If it doesn't work the first time, try again. Okay. So now I can see the screen. How's that?
Yep, we can see your slides now. If you just want to do slideshow, that'll probably work best.
Okay, I can't see you, the chat, or anything else, but onward and upward.
Yeah, that's fine. Just do your thing.
Hello, everyone. Greetings from Patriots territory. Please don't hold that against me. So I'm here to talk about advancing trauma-informed approaches, and particularly try to weave in research and clinical practice. Okay, let's see. Great. You know, it's kind of fun to share financial disclosures because there was a time there was really limited funding for violence, trauma, and abuse. So I do want to acknowledge my funding sources, and particularly 2 grants I'm currently working on with the Robert Wood Johnson Foundation and the Department of Justice. I actually, while I get airtime with all of you today, I do want you to know that I stand on the shoulders of some amazing colleagues who I've listed here. And our work is very much interdisciplinary, and we are even hoping to diversify our team in other ways. But I just wanted to give a shout out to my colleagues.
Annie, this is Emmy. Sorry, jumping in real quick. Thank you so much for starting. Up at the top under display settings. If you switch, we can see your next slide coming. I think you're in the presenter
Okay.
right now. If you want to swap, go to that top one.
Swap presenter view and slideshow.
Perfect.
Is that good?
There you go. Perfect. All right. Keep at it. Thank you.
All right. Thank you. I just learned something new. I appreciate that. I will get an A in Zoom at the end of this semester. I am sure of it. And so as I go through these today, I do want to just make a point, an explicit point here that, you know, some of this discussion might be uncomfortable, and please feel free to take care of yourselves in ways that suit you. So one of the things that struck me early on in my career, and as you've heard, I founded a clinic some years ago, and kudos to my colleague for the work that she's doing out there, and sort of trying to figure out the best care model for these patients. But this is a quote that I've shared for some time, is that we do ask our victims and survivors to embrace and access our services, even though we sort of know that within our systems we have inherent challenges. And I just think of an example. Every day I can come up with an example, but, you know, calling my clinic so that I can help to get a patient booked, and it's press 1, press 3, we're at lunch, call us back. There's lots of challenges, as you can imagine, for our patients, and just, you know, to ground yourself in that, just think about some of the challenges you have. So I was very much interested in creating not so much a system, although I'd love to do that too, but creating a care model that would service our victims and survivors in better ways. And hence, that was the development of the C.A.R.E Clinic. So I wish I could see you all, but I can't. And if we had more time here today, I would ask you, you know, what is trauma? When I say that, what resonates with you? And, you know, maybe type some words in the chat, and when I finish up here, I could go back and look at it. But, you know, if you ask this question of people that work in the emergency room, they're likely going to say, you know, motor vehicle crash, an MI, a bad fall. And so we've tried to define our trauma very broadly, and we do look at it in these sort of 3 concentric circles, which, by the way, are not mutually exclusive. When you think about individual trauma, really it's an event. It could be a series of events. It could be a COVID diagnosis. It could be the loss of a loved one, a motor vehicle crash. It's sort of these event or a series of events that really has some long-lasting impact on the individual. And then if you look at interpersonal violence, it was really a lot that was just discussed in thinking about violence across the lifespan, from child maltreatment up to elder abuse and everything in between, including sexual and domestic violence and human trafficking. And in some instances, I would add in community violence. But one of the things that we've been sort of a little remiss on in healthcare is really addressing collective trauma. And when we say collective trauma, we're talking about sort of that cultural, historical, and socio-political trauma that impacts individuals and communities across generations. And it's really the types of trauma that are seen in institutional barriers, structural racism, the social determinants of health. And again, these traumas are not mutually exclusive. They don't sit in these nice little clean buckets. Rather, there is an intersection between all of them. And I would argue that some of our most complex patients that we care for are impacted by the intersection of all these types of trauma. And thus, our challenge and our opportunity here is really to develop a pedagogy that advances health equity and social justice, where we're paying mindful intention and attention to the traumas that are rooted in structural races, in explicit bias, and unconscious bias. And again, if we think about some of the patients, and those of you in clinical practice or even doing research in areas of health equity, paying attention to the fact that many of the people that we care for and that we're trying to have a deeper meaning of understanding of care models for are impacted by many of these types of violence. And so I can't see you again, but I would ask you to share, how many of you know about ACEs, and maybe someone could give me some sense. I'm not sure how deep to go into ACEs. Certainly, I don't want to spend a lot of time here if everyone is pretty versed on ACEs. Maybe someone could give me a...
This is Emmy. Hard to know because I certainly can't speak for everyone, but I think that this is a concept probably most people have heard of at least. This is an injury prevention kind of crew who've
I gotcha. Yeah. Awesome. Then I'm not going to spend a lot of time other than to say, number one, if you are not, given the program of study that you're in, well versed on this, I would like to think of it as a homework assignment. Please, you can Google this. You can look in Google Scholar. There is probably some 75 to 80 publications on this. Really a landmark study that is just starting to take hold in clinical settings. I can say that in the state of California, being led by Dr. Nadine Burke-Harris, who is a trained pediatrician and is now the Surgeon General in California, that every single child in the state of California is being screened for ACEs. And the big upshot here is that most people have been impacted by some experiences that occurred in their childhood, and that there has been health consequences as a result in their adulthood, which really begs the question. Screening children, we can understand that. If you can understand if a child's being abused or neglected or there's household challenges, understanding that that's occurring and then trying to mitigate that could really prevent some healthcare consequences. But one of the big questions in adults, those are caring for adults, is, what is the added advantage if we're asking adults about their childhood exposures? You can see down in the bottom right there that the higher your ACE score, the more likely you would have these poor health outcomes. And thus, in this original study, they speak about this dose response. The higher your ACE score, the higher the health consequences. I can say anecdotally as a clinician, I'm not sure I 100% agree with that. I've seen some patients that have had an ACE score of maybe 2 or 3 who have had more challenging health outcomes than those of 8, 9, and 10. So it really begs the question for us to further understand what is it? Why does some with a 2 or 3 have higher or more significant health outcomes than somebody with 9 or 10? So if you're not familiar with it, absolutely should be on your reading list. And I did put in one more. If I didn't torture you enough with the first slide, I'm going to give you one more, only because this is hot off the press in November. Another study done on ACEs by the Center for Disease Control using the Behavioral Health Risk Assessment. There were 25 states that participated. I'm not sure if Colorado was one of them, but you could certainly look that up. But you can see a pretty sizable cohort of almost 64,000 people. And again, they found that close to 61% of them had reported at least one of these ACEs, and another almost 16% with 4 or more. The thing that fascinates me about understanding ACEs is really the adjusted odds ratios for health consequences. So if you look down at the bottom there, you can see that if you compare somebody with no ACE score to those with ACE exposures, their odds of developing depression increase by 5, COP by almost 3, smoking by 3, etc. And when these studies are repeated in other populations of diverse race and ethnicity, again, all these odd ratios numbers change. I do some work with American Indians in Shiprock, New Mexico, and that depression score goes up to 22. So, you can see where this has been replicated, and it has been around the country and around the world, quite frankly. On this next slide, again, just another way of sort of depicting the root causes of some of these, consequences that we see. This model grew out of a way to understand the relationship between individual and community trauma. If you look at the leaves on the trees, you'll see these are things that we easily screen for: domestic violence, substance use, etc. But if we're really to understand these challenges, we must look upstream, and we have to look at the root causes. And here we see that the leaves are watered and nurtured by these roots, and those roots, again, are embedded in history, are embedded in systemic oppressions and structural racism, and the social determinants of health. Next slide. I'm talking to myself, next slide. So here you can see the social determinants, which I was just talking about. And I, when I'm teaching with students, I say, so what's missing? There is something missing here when I look at this. And because of the sake of time, I'll just say what's missing is trauma, violence, and abuse, which we know from survey data and large epidemiological data sets that violence, trauma, and abuse are absolutely a social determinant of health and should be included as such. So here are your 6 principles of trauma-informed care. I like to think of these when I think of my program or research. I also like to think of these in my clinical encounters with patients. And I also think about this in my relationship with my peers and my colleagues. You should all know that this was developed in 1994. SAMHSA, the Substance Abuse and Health Service Administration, convened a conference, which was called the Dare to Vision Conference. And this event was intentionally designed to bring trauma to the foreground. It was really the first national conference in which women trauma survivors talked about their experiences and the way in which their standard practices in hospitals re-traumatized and often triggered their memories of previous abuse. And these principles are grounded in evidence, and that evidence offers us an opportunity to engage with patients in more meaningful encounters. And again, if we think about this with sort of a triple aim in our programs of research, in our relationship with our patients, and in our relationship with our colleagues. We like to think of TIC or trauma with a universal awareness. In other words, let's just assume that most patients that we're working with have had some sort of traumatic exposure in their lifetime. Certainly just the mere admission to the hospital with a diagnosis can be trauma in and of itself, right? We call that medical trauma. So we like to think of it as a universal approach. Philosophically, the shift is really moving from what's wrong with you and what's wrong with a patient as far as a problem list or deficits, and using very prescriptive models to using this trauma-informed type approach, which is what has happened to you and how has that impacted you, or how has that affected your health and well-being. So philosophically, it's really a very different shift. It's a shift that felt pretty natural to me, and that, the details of an event are not as important to me as what has the impact that event or that experience has had on your life. And so why do I think this is so important? And particularly for those of you that are going to be direct service and frontline providers or thinking about programs of research, we need to understand that trauma is pervasive. And if I want you to know, I wrote this slide before the COVID epidemic, and I can say that it probably resonates more now with people than before. Trauma is pervasive. People are experiencing levels of trauma in this country that we have never seen the likes of before. And it's not only our patients, but it is the staff and those employed in the hospital, our first responders, law enforcement, ambulance personnel, etc. And so if we didn't think it was a big deal before, I think that there's not too hard to sell that idea now. The other thing is trauma not only impacts people's, mental health, their physical health too. And I'll go through a quick slide on that. But lastly, traumatic experience really influence how people access care and how people experience healthcare. If you are someone that maybe had suffered a non-fatal strangulation by your partner, going in for your physical and having your provider do a thyroid exam on you could be a very triggering event. Patients who have experienced sexual violence, having a gynecological exam for those patients is very different than providing that same exam to someone who hasn't had that experience. So we have to acknowledge that sort of this one model of care that perhaps might work for many does not work for all. And here are just a couple of examples here. Retelling of stories, I'm very interested in that. So I am doing some, my research in this area right now of how can histories be shared in a way where patients don't have to continually tell their story over and over again to suit the needs of the system or the providers. And then you can read some of these other things that many procedures we do that could be quite routine to us are not always routine to our patients. And certainly just the mere act of putting people in vulnerable positions, of physical touch, removing clothing, all of those things can be re-traumatizing, and they can be misread by staff as being uncooperative or over anxious, when in fact it's none of that. It's really related to their past experiences of trauma, which leads nicely into this slide. Many of these patients that we've been talking about today have a fair amount of tolerable and toxic stress. And, we all probably have a fair amount of positive and tolerable stress in our lives. But I think that the population that we're speaking to today, and that's those that have experienced trauma, violence, and abuse, have probably a heavier dose of toxic stress. And while I don't have time to go through this, this whole slide here, many of you are well aware that there is a behavioral and psychological response that happens in the amygdala when we are threatened with something. There's something that's a threat to our safety, either physically or mentally. Most of us will go back to what's called allostasis, and we will, the body will sort of, calm down, our heart rate will come down, and we'll be at this adaptive phase and just go about the rest of our day. But for the patients that we're talking about with trauma, they end up with sort of this allostatic load because they do not seem to get enough time of regulation. They have these repeated stresses that occur that then dysregulate their stress response and end up in pathology. And so many times I see these patients often are labeled in many ways in the hospital because of how their behavioral responses might be to the toxic stress. But when in fact, if we address sort of that regulation and what is causing that sustained toxic stress, I think the interactions and the outcomes would improve significantly. Just a minute here or less, I wanted to share with many of you that are in the front lines and thinking about trauma inquiry that disclosure is not always the goal. And I have to say that there are a few exceptions to that. And certainly, Christine is in a very different place where she has patients coming in, they have been traumatized. She needs a detailed history to guide her clinical practice and what, the workup's going to be for that patient. But any patient outside that acute phase, we don't need to have a full disclosure. I will get calls all the time that there's a patient in the ED with, I know she's being trafficked, but she won't say anything. And I say, well, then give her information. You don't need a disclosure to then be therapeutic or to provide information. So we very much are supporting sort of this move in the field, if you will, to sort of general broad inquiry And details of traumatic stories should really be saved for those that are doing the mental health counseling, or to the degree that you need the information to actually treat the patient. So we're going to give you a couple of questions. I'm going to jump ahead here. So here are these broad inquiry questions. You know, has anything happened in your life that you feel has impacted your health and well-being? Love the question, been using it. It's part of a research study that we're doing now to understand, you know, the effectiveness of asking a question like this, but it's broad. It puts the locus of control of the patient to share as much or as little as they want, and we get at broader trauma. For example, one case of a 24-year-old, long history of substance use disorder, ask her this question after 10 times in the emergency room in 1 year. And she looks at me and she says, well, yep, I guess the car accident I was in at 15 years old, my best friends were killed. And so, you know, she wasn't being trafficked. She wasn't, you know, there was no physical domestic violence or anything like that going on. She had a significant trauma at 15 years old that was then impacting her health and well-being. She was able to name it. I'm proud to share today she's entering her 3rd year of college. So these are some questions for those of you that are in clinical practice and might think about, you know, sort of these broad questions. And I have one other slide, but I'm going to skip it so we can take some questions. I just want to be really proactive here and saying that as you enter into the field and you think of your careers ahead, whether it's in research or clinical practice or academia, we all got to think about this. It took me a long time in my career to think about it, and you can't use it as an afterthought. We can't be thinking of it and only when we're burnt out. We have to proactively think about how we can do the work that we're doing and take care of ourselves. And so on that note, I'm going to stop.
Great. Thank you both so much for that. I know we're near the top of the hour, so to participants who have to leave, we will be sending out a link to the recording. But I want to see if there are any other questions coming in, if folks have. Otherwise, I would might ask to, especially Christine, for folks who are local, could you talk about how they might partner to get to look at data? I mean, I think usually it would probably go through some kind of relationship with the university and so forth, but if you have any thoughts on that, who's the best person to contact if they're interested in doing research related to the F&E program?
Yeah, great question. They can certainly reach out to either myself or the assistant nurse manager, Loretta Chu. I will put our emails in the chat. Loretta actually just started her PhD program, and I think would be an incredible resource for something like that. In terms of data, you know, I'm very transparent with that. I'm happy to share that. You know, what I showed you all today was a very, very small snippet of all the data that Loretta painstakingly collects on each patient that we see. So, you know, I could go on and on about data. There's quite a few data points that are being looked at and a few that we're actually going to add for 2021 as well. I do share probably about 10 to 12 slides with senior leadership on the UCHealth campus every month. So I already really have the slides made up, and if someone wanted to see some of that, I'm happy to share. But yeah, I think just reaching out to Loretta or me would be a great way to talk about some possible research. We actually just are getting ready to start a research study with Dr. Berkowitz on starting our sexual assault patients on, Prazosin. Sorry, the name escaped me for a second. There's a lot of, you know, use for after someone has developed PTSD to mitigate nightmares, but the study is surrounding starting it prophylactically, starting it when, you know, at the time of the exam that the patient has with us, and seeing if that helps to mitigate PTSD. So really exciting, but, you know, he got connected to us, and I'm very excited about our partnership with that study. But yeah, certainly, and I'll put our emails right now in the chat. Oh, I think.
Yeah, thank you so much. And if you have trouble finding them, if you have my email, feel free to email me as well. One last question. I'll also remind folks, November 1st will be our next webinar. We will be sending out information as well as the link. But last question is from a student wondering if you're interested, if he or she is interested in pursuing SANE or FNE practice. Are there certain areas of experience that are required or helpful to get into the field? Oh, I think you're muted, Christine.
Sorry. Yes, most programs require between 1 to 5 years of acute care experience. So that's really important. And you know, that is very general. Usually it's some type of hospital setting, or even if it's like an urgent care type clinical setting. But, you know, we do need to have very astute assessment skills, and we do that very thorough head to toe. You know, we provide a ton of education. Our average orientation lasts about 3 months, and that's for experienced nurses, because often the principles we're using haven't been taught elsewhere or haven't been taught thoroughly elsewhere. But yes, they do have to have acute care experience. So if that's the path you want to go on, you know, I highly recommend getting a few years of acute care experience and then going into that forensic nursing training. There is a 64-hour online sexual assault training offered through Sigma Theta Tau. And then for those that are Colorado residents, there's also an online training offered through a grant through our counterpart in the South, in the Springs, the UCHealth Memorial folks. If anyone wants to reach out to me, I'm happy to provide all that information and kind of help you get outlined on what your education path would look like.
Thank you both so much. I think we are now out of time officially. So I will just say thanks. If it's okay, we will put, Christine, you and Loretta, your emails in the what we send out to attendees. Thank you all for joining us. Thank you, Annie, for bringing up how important it is we take care of ourselves and each other as well. So be safe and be well, and see you next month. Thank you.
Bye-bye.
Bye.